Good afternoon. Can all of you hear me? Am I audible? Can you hear me now? Oh, perfect. Good afternoon. I am Dr. Huda and I am a graduate of Dar University. And welcome to the Med Exam webinar for MRCP Part 1. A little about myself. I am Dr. Huda and I graduated from Dar University of Health Sciences. After that, I did my internal medicine residency this year, and I also did my MRCP exams. In today's webinar, we will be discussing a little bit about the examination preparation and the learning resources that you can use for your examination preparation. Along with that, how to utilize the examination recalls and the mock exams to your maximum benefit so that you score well on the exam. I will also help you to practice solving the questions in such a way that you're able to answer the questions in less than a minute that you are expected to do on the exam. So let's begin. Am I audible? Is there anything that I'm audible? Now, the examination pattern, a little bit about the examination pattern. The examination has 200 questions and they are divided in two sections of 100 questions each. And for each set of 100 questions, you will be given 3 hours to solve them. And there will be a break of about an hour in between. And then you'll have another 3-hour session after that. So the entire exam is for over 7 hours. And you have both the exams on the same day. So this is how the exam is designed. There will only be best choice answers. There will not be any pictures or any visual, no x-rays, no ECG that much. There will only be a straightforward questions, scenario-based question, and you'll have to pick the best option out of each of them. Yes, Dr. Veera, you're supposed to ask me something. Please unmute yourself and ask your question. Okay. So a little bit about the preparation. Now, there are multiple views about how long you should prepare for the exam in order to be able to score well. So you have people, the preparation time can range from 3 months up to a year, depending on how good your background knowledge is. But I always recommend my juniors and my colleagues to take ample time as per their preparation and try not to rush towards the exam and do not give an immature attempt. So ideally, it should take you about 5 to 6 months to prepare. And the tip that I give my juniors is that before booking the exam, before booking date for the exam, ideally you should have completed at least one grade from your main QMAT. Okay. You should have completed at least one grade. That way you'll be a little more confident when you book your exam that you will be able to score well. And obviously the preparation will depend on the number of study hours that you give. There will be candidates who can prepare for 7 to 8 hours per day, and there will be candidates who have full-time residency or full-time clinical practice, and they can only take out a few hours. So keep your own routine, your own learning pace in mind, and then try to book the exam. Another point is the background knowledge of the candidates. If you're a young, a fresh graduate, you will find some topics very easy. You will find clinical pharmacology and clinical sciences very easy. But if you're an older graduate, you might have a little bit of problem there, and it will take some time before you are able to polish that part of your examination preparation. So that you should keep that in mind before you're booking your exam. The next thing that we discuss about are the resources. There are a lot of resources that are present in the market at the moment. Some of them are online key banks, some of them are PDFs, some of them are the handouts or the hard copies of the books. You can choose any two key banks. I like to use two key banks. One is used as a learning tool, and the second one is used as a recall or a revision kind of for revision purposes. Like, for example, if you're using one question bank, try to go through it in so much detail that you kind of know each and every line that is written in that question bank. And I will show you how you can study in a more effective manner and how you can utilize your question banks to maximum potential. So use two Q banks, use one for learning purpose and the other one for a fast revision. Then the examination recalls. As such, the questions are never repeated. And these questions that you see circulating on your social media site are never the true questions that came in the exam. They always recalls of the exam. So you can use them to see the concepts and the concept that are tested on the exam, but they're never actually repeated. So you can have a question on asthma. So you can decide whether it's you can be asked about different types of you can be asked for diagnosis of asthma, or you can be asked for the management of asthma, or you can be asked for the prognosis or the any of the features of clinical features of asthma, but never the exact question. Then the next thing are the notes. A lot of notes are present already, and some of them are from international authors, some of them are from the locally based authors, some of them have a little outdated guidelines, and some of them are quite extensive. So what I suggest is you take 2 or 3 PDFs, take the PDF of all the notes that are available for you, and then we take one particular topic. For example, it's asthma because the guidelines keep on changing. So take that one topic and read it in all the notes, and then see which notes are more easier for you to recall and easier for you to revise. So in that way, you'll be able to revise it before the exam, because at the end of the day, you have to revise those notes. So if the language is a little more familiar for you, if you find that language more comfortable, you can use those notes. And then use it and take it as a proper learning source and keep on revising those notes again and again. So before the exam, when you take them out and you kind of revise them, so it's easier for you to revise. Then the last thing that we can discuss are the mock exams and the Royal College of Physicians sample paper. The mock exams that will be conducted by med exam expert also, you can solve them. Will be very effective for your preparation, for your time management, and to see which topics are you weak in, so that you can revise those topics again. And the Royal College of Physicians sample paper that is present on their website, which is very, very important, and I cannot emphasize that enough. And you should solve that paper at least 15 days before your exam. Do not try to solve it a day or two before your exam, because it will give you a percentage of your correct answers, and that could either panic you out or that could make you more overconfident or underconfident. So it's better to do it a couple of days before the exam, so that it's easier for you to just learn the mistakes that you've done that, and try to practice a little bit more regarding the time management. So any questions so far? Any questions? Anything you would like to ask before we begin to next part of our webinar?
Hello.
Yes, doctor. Good afternoon. Is there a question?
Yes, ma'am.
Then data. I can hear you.
Hello.
Hello.
Hello. Yeah, ma'am.
Hello. Hello. Good afternoon. Yes, I can hear you.
Can you hear me? Yeah.
Yes, I can hear you. Okay, no problem. We'll take that question at the end of the session. It's not a problem. I'll answer. I can't hear you. Okay. Now, this is chart that is given in. This is given on the Royal College of Physicians website as well. And this table just give you an idea of how many questions will be present from each system. So that will help you in your preparation, that you can focus on some systems more which have a lot of weightage on the exam, and you should not ignore those systems. For example, cardiology is heavily tested, clinical pharmacology is heavily tested. A lot of internal medicine have problems with clinical pharmacology. It's been a long time they've revised all of that. I'll tell you what to understand in that. A lot of candidates have problems with clinical sciences. There were a lot of questions on endocrinology, from diabetes, from other metabolic disorders. You will have a lot of questions on gastroenterology. Infectious diseases heavily tested, and it is a problem for the candidates for the IMGs, because the infectious diseases are very heavily tested on the MRCP exam. Urology is heavily tested, along with that renal, respiratory, and hematology are heavily tested. That does definitely not mean that you keep the other, you ignore the other system, but the point is that these systems are heavily tested and you need to know each and everything that you can possibly study about them. Clinical sciences itself comprises of cell, molecular, and membrane biology, anatomy, biochemistry, physiology, genetic, immunology, and statistics. So these things are little outdated for the residents or for older graduates. So you have to work a little harder on these systems. Now, a main problem that candidates face during the exam is the time management. You have to solve 100 questions, 180 minutes. So you have less than 2 minutes for each question. So a lot of candidates have a problem that they have to read the question again and again in order to try to get the concept what the question is asking. And there is a lot of irrelevant information that is present in the form of tables or in a lot of extra details are given in the scenarios, and that wastes a lot of your time. So by the time you're able to start solving the answer, then you'll have to read the scenario all over again. So I'll give you a small technique of how to read the question in a way that you do not have to read it again, and you do not miss any important detail while reading that question. So here is a question which has a lot of information, a 4 or 5 line or 6 line scenario, along with a very large table with lots of information, lots of lab mentioned. So the question is about a 67-year-old retired builder who comes to the respiratory clinic for review. He has been diagnosed with asbestosis, and he has progressive shortness of breath and increased exercise tolerance. He smokes 20 cigarettes per day. The examination reveals consistent crackles with pulmonary fibrosis and some wheeze consistent with chronic obstructive pulmonary disease. Then there are a series of investigations which are mentioned along with an X-ray which shows multinodular opacities, pleural flags, and a CT scan which shows subpleural linear densities, basilar and dorsal lung parenchymal fibrosis, peribronchiolar, interlobular, and interlobular septal fibrosis. So there's a lot of information that you have to go through. And what are they asking you regarding this question? Which of the following measures will be the most effective to slow down the progression of fibrosis? And then you're given 5 options: cyclophosphamide, high-dose corticosteroids, home oxygen, prednisolone, and smoking cessation. Any idea what the answer might be? And then I'll tell you the
Smoking.
answer that. Okay.
Smoking?
Okay. Now there's another way where we can solve this in. Now this is a question just asking you a very straightforward thing. But now let's read the question again in such a way that we do not miss any information, and we read it in less than a minute. For example, now what you do whenever you're practicing, even during your practice sessions or you're studying it for the first time, always keep a pencil or a highlighter in your hand. Even in the exam, you can use that pencil and start marking the important relevant points in that clinical vignette. For example, in this clinical vignette, what are the important points? What are the important features that you can you'll find in the scenario? Anyone? One? Okay, problem. Okay. Now you have a scenario where they're mentioning a 67-year-old. So this is an important point. Feature is the age is an important factor. Then patient is a builder, so an occupation is important. And then he's coming to the respiratory clinic. You've read one sentence and you know so many things, and then the old age man who's a builder and he's coming to the respiratory clinic, or already your brain has started brainstorming that this is something regarding an occupational lung disease, probably. Then they're already telling that the patient has been diagnosed with asbestosis and he has progressive shortness of breath and decreased tolerance. He smokes 20 cigarettes per day, so you know he's a smoker. And the examination reveals fractures consistent with fibrosis. So you already know there's fibrosis. And there is some wheeze consistent with chronic obstructive pulmonary disease. So you already know there's fibrosis, he's a smoker, he has asbestos. So you know all the information. Now this table per se is irrelevant, but what I would do would keep pencil in hand and just go through the lab in the first sheet and see what is the important lab deviation that is present. Hemoglobin is okay, the white cell count is fine, platelets are okay, sodium is all right, potassium is okay, creatinine is all right. Now, all of this information is irrelevant for you. Now, the chest x-ray. Now, the chest X-ray is showing you on multinodular obesities and pleural plaques. So, you know, this is asbestosis. And then the CT is showing you some fibrosis. So, all of this information which was present in the table is not important for you at the moment. The only thing that you need to know is that the patient has asbestosis with fibrosis and chronic obstructive pulmonary disease. So, you're right, the answer is smoking cessation. But if you try to read the scenario again and again, it will take a lot of your time. So when you're reading it for the first time, just extract all the relevant information and then try to solve the answer. So, which of the following measures will be the most effective to slow down progression? Yes, smoking cessation is the correct answer. And smoking accelerates the progression of fibrosis in patients with asbestosis. It will also increase the risk of exacerbation of smoking-related lung disease. As such, the most important way this man can influence his prognosis is by stopping smoking. Pneumococcal and influenza vaccinations are also important. So this all information is an extension of the answer. Now, when you're studying for your exam and you're solving this in your question bank, for example, or your examination recall, how will you utilize this question to the maximum, to your maximum benefit? What you will do is you will see what other questions can be asked from this question. For example, you were asked about a 67-year-old patient who was a builder. You could have been asked what the disease he might have. If they did not have mentioned asbestosis, they could have asked you about the diagnosis of the disease. That could have been one thing. They could have asked you about the fibrosis, whether the patient had fibrosis, what clinical feature he might have had, or which complication he could have developed as a result of that. There could have been a lot of questions that could have been asked from this question only, framed in a different way. So in that particular question, you could have been asked about occupational lung diseases. You could have been asked about fibrosis. You could have been asked about COPD, any other way of COPD. You could have been asked about the prognosis. You could have been asked about the long-term oxygen therapy. You could have been asked about any of the other treatment modalities. You could have been asked about smoking cessation. You could have been asked about how to stop smoking. The methods of stopping the smoking. How could you so there could have been a lot of different questions that could have been asked from a scenario that could have been styled in the same way, but different things could have been asked. Do you get my point? What I'm trying to explain? That when you're studying a question in your question banks, do not Try to learn the answer from them. Try to understand that what are they trying to ask you and what could have been asked in any other form. Is this clear?
Yes. Yes.
Okay, now let's get to the next question. Now, this is a very straightforward question. You're reviewing, there will be some questions which are extensive, which will be about 6, 7, 8 lines with a lot of information in the form of table. But there will be some questions which will be straight one-liners and with yes or no as an answer. Either you know the answer or you don't know the answer. And if you know the answer, that's a bonus for you, that it will save a lot of your time and it will be a short, correct answer. For example, a question like this. We were reviewing the results of autoantibody screening for a 45-year-old woman who presents with small joint polyarthritis. She had found to be rheumatoid factor positive. So you already know that she is rheumatoid factor positive. So what is the rheumatoid factor? Is it an immunoglobulin A? Is it an immunoglobulin D? Is it an immunoglobulin E? Is it an immunoglobulin G or is it an immunoglobulin M?
IgG.
Immunoglobulin M.
IgG.
It's IgM. It's Fc portion of IgG and IgM.
IgM.
The molecule is IgM. But the factor
it's the
binds to
IgM.
the Fc
It's
portion of
basically
IgM.
IgM, which binds to the IgG part. They are the IgM immunoglobulins which bind to IgG and then the antibodies form. Okay. So they are immunoglobulin M are rheumatoid factors and antibodies which are directed against the fragment crystallizable region of IgG, and they are heterogeneous and are usually composed of IgM. Only rarely do they comprise other immunoglobulin subtypes, and they may be seen in a number of other autoimmune, infective, and inflammatory conditions apart from rheumatoid arthritis. So basically, now this was a very straightforward question. You knew that they are IgM antibodies against the IgG component. Now, what else could have been asked in this question? You might have only been given the name of the antibody and asked about the disease, or otherwise you could have been asked about the diagnostic criteria of rheumatoid arthritis. You could have been given a scenario like this and you could have been asked what would be the clinical feature that could have been present in this patient. Or you could have been given a clinical scenario with a woman having joint pains in the small joints, and you could have been asked what would be the diagnostic testing in this patient. Could be have been asked about the treatments of this patient and how could you treat the patient. You could have been asked about the side effects of that treatment, or you could have been asked about the complications of this disease. So there is a lot of ways that this rheumatoid arthritis simple disease could have been asked. So whenever you solve a question like this, always keep in mind what other ways you could be tested in the exam regarding this particular clinical concept. Okay. Okay. Now the next question. Again, a very long question with a lot of information. Now let's start reading it. Patient is a 58-year-old man. He is reviewed in the clinic following a third admission for the past year with hepatic encephalopathy, despite his regular medications, which include propranolol and lactulose, and attending for surveillance endoscopy and pharyngeal banding. Examination reveals blood pressure of 100 by 70. He has mild ascites and pitting edema affecting both the ankles. Now there's a lot of information in the table again. Now, how will we go about it again? Now, for example, we have 58-year-old man. He's reviewed following the third admission. He was admitted with hepatic encephalopathy. Despite taking medication, he was already taking propranolol and lactulose and attending for surveillance endoscopy and pharyngeal banding. So you already know that this is decompensated chronic liver disease. The patient presents with a blood pressure of 100 by 70. He has mild ascites and pitting edema affecting both the ankles. Now, when you're reading the table, just extract the information that you really need. His hemoglobin is 10.2, so he's anemic. His white cell count is normal. The platelets are 85,000, they are low. You already know that the patient is in case of decompensated chronic liver disease, the platelets will be low. Sodium is 136, it is okay. The potassium is 3.8, it is again in the normal range. Creatinine is 89 micromoles per liter, this is also normal. Alanine aminotransferase, ALT, is slightly raised, and alkaline phosphatase is also slightly raised. This is all the information that you get from this scenario. Now, what are you being asked? You're asked which of the following is the best way to reduce the further risk of encephalopathy in this patient. So all of the scenarios, all of that entire scenario that we had nothing to do with the question itself. So if you've read the question, if you've read the last line of the question, and then just skim through the main stem of the question, you would have been easily able to answer. Yes, the correct answer is refractory. Rifaximin reduced the incidence of hepatic encephalopathy over a 6-month period from 46% to 22% and decreased hospital admission by 50% with the registration clinical trial added on to regular lactulose. For this reason, it is endorsed by the National Institute of Healthcare and Health and Care Excellence for the prevention of recurrent hepatic encephalopathy. Now, one more thing that when you're reading, when you're preparing for your exam, you're using a question bank, always see the other options as well. When are the other options used? For example, when is terlipressin used? When is the low protein diet indicated? When is clindamycin indicated? So if you have an idea, you will be able to rule out the wrong answers as well. We will discuss the questions ahead, where it might be difficult to pick out the correct option, but we'll be able to rule out the wrong ones out. So again, if in this scenario, there could have been, this scenario could have been asked, you could have been tested for a lot of different concepts on the basis of the single question. In this scenario, you could have been given a scenario like this with the patient with hepatic encephalopathy, and you could have been asked about the etiology of the hepatic of the decompensated liver disease. You could have been asked about the clinical presentation. You've been asked about the diagnosis. You could have been asked about treatment, which you were asked. You could have been asked about the complications and the prevention of complications and the treatment of complications. You could have been asked about hepatocellular carcinoma. You could have been asked about the monitoring of the patient with hepatocellular carcinoma. So there could have been, it could have been asked a lot of different ways. Okay. The next question. Again, a question with a lot of different clinical information. A 65-year-old man is reviewed on the emergency department after admission with a renal stone associated with left-sided renal colic. The stone was passed successfully. Although the initial abdominal X-ray was negative, the stone was identified on ultrasound scan. The patient is obese with a body mass index of 35 kg per meter square, and he suffers from hypertension and hyperlipidemia. Medications include losartan and atorvastatin. His blood pressure is 145 by 88 millimeters of mercury. Again, a lot of information that would have been important for this question. Then the labs also. Now, if you start to underline what actually was important, it was the age of the patient and whether the patient presented emergency or presented electively at a clinic. That is important. And then he presented with a renal stone and left-sided renal colic. The stone was passed. Now, what you were asked that the stone was identified on an ultrasound scan. Okay, that means that the stone was radiolucent. It was not radiopaque. The patient was obese, so you get the risk factor with a body mass index of 35. He suffers from hypertension and hyperlipidemia. The medications are also mentioned that he uses losartan and atorvastatin, and he is still hypertensive. Now the labs are also important. The labs show that the hemoglobin is 13.6, it is normal. The white cell count is normal. The platelets counts are okay. Sodium is in the normal range. Potassium is also normal. Creatinine is slightly at the higher side. Calcium is okay, the patient is not hypercalcemic. Now uric acid is raised. So this is the only important information that you get from this clinical scenario, and the creatinine level as well. These two things are you should know, and you should have marked this in the first read, and that will help you to answer the question. Now, what is the question actually asking you? They're asking you which of the following is the most appropriate intervention to prevent the formation of renal stone. They're not asking you the treatment, they're asking you the prevention of future stones. So what would be the answer?
What be option E?
Anything?
Allopurinol. A.
It's
B option.
allopurinol.
Anything else? Anybody thinking of anything else? Okay. A lot of you say
Option B.
allopurinol. Why not benzbromarone? Why not this option? Okay, anybody could tell me
Calcium.
what is the
Uric
mode of
acid-
action of benzbromarone?
Oh,
I think calcium is normal for potassium citrate and bendroflumetazide. Calcium is normal.
Yes. Right. What about
Why not
benzbromarone?
rasbirocase? Thiazides cause the hyperuricemia, so they should be avoided rather than to prevent the hyperuremic stone.
Anything else? Okay. Now, the correct option is actually allopurinol. The aim of this entire exercise was that when you get a question like this, you have a lot of options. So you should know what the actual answer is and why the other option is wrong. For example, benzbromarone. Benzbromarone is also uricase. It is also used in place of allopurinol in cases the patient does not tolerate allopurinol. So in case this question could have mentioned that the patient has a hypersensitivity reaction to allopurinol, then what you could have used? Then you could have used benzbromarone. So that is why you should know what the other options are used for. For example, benzofluoromethazide. You correct that it promotes the formation of stone, so that is why it's not used. So you should know what exactly the other drugs are used for, and that you will do it when you're preparing, when you're studying for your question banks. At that time, only when you get the other option, just take a minute to read why the other option is wrong, and not just the correct options. Okay. The patient has hyperuricemia and renal stone that was visible on ultrasound but not on an X-ray, confirming that it is likely to be a urate stone. In conjunction with reducing the consumption of purines in the diet, a xanthine oxidase inhibitor such as an allopurinol is the most appropriate initial intervention. It should be up-titrated to drive the serum urate level to the normal range if possible. So basically, you could have been asked about the type of stone in this question. Now, renal calculi, basically the concept of this question was renal calculi. You could have been asked about the type or the composition of the calculi. You could have been asked about the risk factors of the calculi. You had a lot of risk factors in this patient. You could have been given a scenario and asked what the risk factors that were present in the patient. You could have been asked about the complications and the management. You could have been asked about the drugs which promote the formation of stone and which drugs prevent the formation of stone. So these both these categories are very important. Is it clear? Everybody fine?
yes.
Somebody has asked that how can a person overcome confusion and answers like stems are the same. I did not get your question. Please kindly elaborate. What are you trying to ask? A 65-year-old man who has type 2 diabetes and hypertension is admitted to the emergency department with sudden onset nausea, vomiting, and vertigo. So now you have a lot of information in this single one line. His blood pressure is 185 by 100. His pulse is 95 and regular. He has left-sided corner syndrome, a reduced left-sided corneal reflex, and paralysis of the soft palate on the left-hand side. He also has nystagmus. There is loss of pain and temperature sensation affecting the trunk and limbs on the right. If you have a lot of information in this clinical scenario, and we just so now if you start highlighting the important information, it would be a 65-year-old man, the age is important, then the risk factors like diabetes, hypertension, and then he is presenting to the emergency department with a sudden onset, nausea, vomiting, and vertigo. So you automatically rule out malignancies, you rule out other chronic diseases in one go. You now are very limited to few diseases or like infections, or with just one line, you'll be able to sort that out that you have either a stroke or a sudden onset illness, or and then you can further start solving the question. Now his blood pressure is 185 by 100. His pulse is 95 and regular. He has left-sided Horner, so now you start localizing the lesion. He has a left-sided Horner syndrome, a reduced left-sided corneal reflex, and paralysis of the soft palate. He has nystagmus, and there is loss of pain and temperature sensation. Now I'm moving to the last. Now you just kind of rule out which is the irrelevant information and what you really need to remember. The hemoglobin is normal, the white cell count is normal, platelets are normal, sodium is okay, potassium is in the normal range, and the CT scan does not show any hemorrhage. So now what are you asked? Where is the most likely site of this arterial occlusion leading to this patient's stroke?
Vertebral artery. It is posterior inferior cerebral artery, which is a branch of the vertebral artery.
Yes, that's the correct answer. It's the vertebral artery. The clinical features are consistent with the lateral medullary syndrome, which often occurs as a result of the vertebral artery occlusion. More rarely, it occurs as a result of posterior inferior cerebellar artery occlusion. Other key features that stand out in the scenario, such as the vestibular system disturbance, the patient has nystagmus, the patient has vertigo, the patient has vomiting, Horner syndrome, nystagmus, reduced corneal reflex, and palatal paralysis, coupled with contralateral sensory loss. As with other stroke, antiplatelet agents with the management of vascular risk factors, such as hypertension and lipid control are crucial for preventing further events. So again, now the scenario is about stroke. Stroke is very, very heavily tested on the exam. You will always have 5 to 8 to 10 questions regarding stroke. And it will be asked number of ways. You can be asked about the risk factors of stroke. You can be asked about the location of stroke. For example, you could have been given the lesion and you will be asked what is the site of the lesion. Or you could have been given the vessel and you could have been asked what clinical feature would have been present in this patient. And one thing that you need to remember is the dominant and the non-dominant side. For example, you're given the lesion of the speech, you're given a lesion of Broca's area, you should know whether it's the dominant frontal or the non-dominant. So that is important. And if the patient is right-sided or left-sided, it's always mentioned in the scenario. Clinical manifestations are asked, the investigations are questioned. You are asked about the acute management. Always see time of the stroke given. If it's whether it's in the time frame of the thrombolysis or if it's not, and what are the contraindications of thrombolysis? It's always asked. And the long-term management of the palliative care. And you're also asked about the control of the risk factors. You're always asked about hypertension, anticoagulation, the patient has atrial fibrillation. You're asked about that. If the patient has some for a patent for a manual, or if he has some, so that is always asked. So always whenever you study stroke, that is a lot of detail. So do you get the point that whenever you have before every exam, before your MRCP or MRCP part 1, part 2, or any exam that you can take, always revise blood circulation of the brain before your exam, because a lot of time you will be asked about this, and if you get that right, that will be a short correct answer on your part. And so always study stroke very carefully. So you get my point?
Yes.
Now, this is another scenario where we have a 56-year-old man, Pakistani heritage, and he comes to the clinic to discuss how to manage his diabetes during Ramzan, as he intends to observe the religious fast. He has type 2 diabetes for the past 5 years, and he currently takes metformin 500 mg 3 times daily. His body mass index is 32 kgs per meter square. So you're simply asked about how to manage the diabetes. Either you know it or you don't know it. There's no guessing in this part. So you should know about a little bit about the management of diabetes in different clinical scenarios. We'll discuss that also. So his hemoglobin is 14.5, WBC count is 7, platelets are 233,000, it's normal. His sodium is 144, it is normal. His potassium is 4.5. His creatinine is 94, which is in normal range. And if A1C is 54, which is slightly on the high side, but more or less well-controlled diabetes. So basically, you simply ask how to regulate his metformin levels so that the patient can fast. So what would be the most appropriate way to manage blood glucose level during the fast? So the options are leave dosing of metformin unchanged, change metformin to glycoside, change metformin to pioglitazone, change dosing schedule to 500 mg in the morning and 1 gram in the evening, or omit metformin during the fast.
You can change the dosing to 500 in the morning and 1 gram in the evening, because he'll be having 2 meals, one early morning and one after sunset. So you can just change the dosing.
Yes, basically, that's the correct answer. Because what will happen is that the patient is having his breakfast or the meal, and then he will not be having anything throughout the day. And then he will be eating in the evening, and then he will continue to eat during that night. So that is why you have to give a higher dose in the evening, and then you have to give you have to give 2/3 in the evening and 1/3 in the morning.
Mornings, I mean before dawn, sahur.
So it is before dawn.
Yeah, okay.
So you will change the dose to 500 mg in the morning and 1 gram in the evening. And the primary mode of action of metformin is to reduce hepatic glucose output. It does not stimulate insulin release from the pancreas, and used as a monotherapy, it is not therefore associated with hypoglycemia. But the dosing schedule will not fit with their fasting needs, therefore changing the dosing regimen will be beneficial. Basically, we're not studying the exact the entire topic at the moment, but I'm just giving you an idea of how you will be tested regarding each topic. So in this question, the patient, you were asked about diabetes, and you can be asked about diabetes in a number of different ways. You can be asked about the pathophysiology of diabetes, of type 1 diabetes, type 2 diabetes. You can be asked about the diagnostic criteria, the fasting glucose levels, the oral glucose tolerance test, about the HbA1c, the factors which alter the HbA1c levels. You can be asked about the inherited disorders, the maturity onset diabetes of the young, or the related or the LADA type diabetes. You can be asked about the management, and this is very important. It's always asked in the exam. You will be asked about the management in the elderly patients. You can be asked about, because in elderly patients you cannot afford to have hypoglycemic episodes. In obese patients, you have to always keep a drug. You have to add a drug which will activate or which will accelerate their weight loss mechanisms, and which do not cause weight gain. In pregnant patients, how will you how will you diagnose gestational diabetes? How will you manage gestational diabetes and the complications of gestational diabetes? All of these things are very important. Then in CKD, you have to alter the dosing schedules of, you have to reduce the dose of certain drugs. That is why it's very important. Fasting states are important.
Oui.
Then
How many
you will be asked about diabetic ketoacidosis. That is very important. Again, the diagnosis of diabetic ketoacidosis, treatment, management, the follow-ups of diabetic ketoacidosis. You can be asked about the complications, the microvascular and the macrovascular complications. You can be asked about nephropathy, the classification of diabetic nephropathy. You can be asked about neuropathy and retinopathy. All of these things are very important. I can hear somebody if I'm talking. You could kindly mute yourself to not ask me anything. I can hear somebody in the background. So you get my point that a simple question like this could be asked in a number of other ways. So you always have to keep in mind when you're studying diabetes, always keep in mind that you can be asked about so many different things, especially the management part is very important. Whenever you're studying, always keep in mind side effect of the drugs. For example, exenatide causes pancreatitis, or which drug causes which is contraindicated in heart failure, or which ones are indicated in heart failure. So you always have to keep these things in mind. Now the next question. We have a 28-year-old man who presents to the emergency department with central chest pain, which is worse on inspiration and which is relieved on sitting forward. He has been suffering from flu-like illness which began a few days before the chest pain and is also suffering from intermittent fast palpitations. His blood pressure is 122 by 82 millimeters of mercury. His blood pressure is 75 beats per minute and regular. His chest is clear. So again, we have a lot of information that the scenario is about a 28-year-old man. If you start marking this right away when you're reading it for the first time, you would not have to do this entire exercise all over again. So whenever you're reading, just start marking it. It's about a 28-year-old man. He is presenting to the emergency department. The patient has central chest pain, which is worse on inspiration and relieved on sitting forward. You already get a lot of information. You might have reached a diagnosis there and then. He has been suffering from flu-like illness, which began a few days before the chest pain, and is also suffering from intermittent fast palpitations. His blood pressure is 122 by 82 millimeters of mercury. Pulse is 75 beats per minute and regular. The chest is clear. Now, again, you have a series of information in the form of a table. Now, you just quickly skim through it that the hemoglobin is normal, the white cell count is normal, the platelets are fine, sodium is okay. It's normal because the electrolyte imbalances are very important in young patients who present with chest pain or with other cardiac complications. Potassium was 4.3, it is in the normal range. Creatinine is 95 micromoles, it is again in the normal range, and troponin is also normal. Now, which of the following is most likely to be found on the electrocardiogram? First of all, just keep in your mind that what is the disease, what is the diagnosis, and then what would be the ECG finding.
Pericarditis.
Mostly it's ST elevation.
That's
This is-
pericarditis.
It's very correct. So there will be saddle-shaped ST elevation in almost all the leads. D will be the answer.
D
Yes.
would be the answer. Saddle-shaped ST elevation.
Yes, it is D. Now, why is it not convex ST elevations present in the anterior leads? Now, see, when you have a question like this, you should, when you're studying for the exam and when you get a question like this during your preparatory phase, always see what the other options mean. What are the other options standing for? Convex, where would you see a convex ST elevation in the anterior leads?
Anterior wall MI.
Exactly, in an anterior wall MI. Where would you see a PR prolongation?
Heart blocks.
Heart blocks.
In a heart block, correct. Where would you see a QT prolongation?
QT, prolonged QT syndromes and certain drugs, antibiotics
Yes.
and all.
Exactly. So if for example in this scenario you were given about a flu-like illness and the name of an antibiotic could have been mentioned, then your answer could have changed, right? So you should always know what the other options are, what the other options stand for. Now you know that this is an sergeant shaped ST elevation. Now where would you see a T wave inversion and the inferior leads? Where will you find a T wave inversion in the inferior leads?
Potassium level are elevated is typically maybe
Yes,
T wave.
in a non-ST elevated MI of the inferior wall.
No.
So that is why it's important that whenever you are studying about ECG, always read through the other options and see what the other options mean and what the other option, when will you see the other ECG findings, so that whenever you get a different kind of a question, you always know what you have to mark. Okay. Now you will get a saddle shaped ST elevation in mostly. So a widespread saddle shaped ST elevation is a feature of pericarditis. The most likely diagnosis here. Symptoms of flu-like illness suggest a viral etiology. Although pericardial drug may be present in auscultation of the chest, it is not required to make the diagnosis. Then you could have also been asked what would have been the treatment for this patient. So you would be giving NSAIDs, and colchicine might have been added for patients with residual pain. Patients should be advised to be strict physical activity until symptoms have subsided. Any biomarkers of inflammation have returned to normal range. So you could have been asked about it in this question in a number of different ways. You could have been asked about any other disease with a peculiar ECG finding. You could have been asked about hypertrophic obstructive cardiomyopathy. You could have been asked about Wolff Parkinson White syndrome. You could have been asked about pericarditis or any other different disease with peculiar. You could have been asked about Brugada syndrome. You could have been asked about an acute MI. You could have been given about particular electrolyte abnormality. You could have been given about hypokalemia, hyperkalemia, hypocalcemia, any different abnormality with any particular with a particular ECG finding. You could have been asked about arrhythmias. You could have been asked about atrial fibrillation, atrial flutter. You could have been, and then you should always know the management of the underlying condition. For example, now when we were saying that convex ST elevation was present in the anterior leads in an anterior wall MI, you should know how would you manage an anterior wall MI. If you're getting PR prolongation in the heart block, how would you manage that heart block? If you're getting QT prolongation, how will you manage that? So you should always know the management of each kind of ECG change that you're getting and when the patient presents to you in an emergency. Is it clear? I know it's a lot of information to process, but I'm just giving you an idea. So when you start preparing for your exam and when you start solving question bank, you know what exactly you need to learn instead of trying to learn the explanations. Just try to learn what exactly you need to know for the exam. Okay, now this is a question that I want you to understand. If there's a patient who is a 21-year-old man with cerebral palsy, and he comes to the emergency department with increased drowsiness, which may be related to a urinary tract infection. He is taking baclofen to cold muscle spasms. Which of the following accurately describes the mode of action of baclofen? Very, very easy question. If you know the answer, you know the answer. And if you know the mode of action, you do not really need to know the entire scenario. So if you know what the answer is, you can let me know.
It is a GABA B agonist, so it will be B.
Doctor, could you go to saddle-shaped explanation? But I want to make a photo. Saddle-shaped explain. No, the previous one. Yes, this just hold. Thank you very much, Doctor.
You don't really need to take any pictures. You'll be whenever you start studying, you'll get this question again and again, over and over again in any question bank that you solve. No,
Thanks.
don't need to
Thanks,
worry. I'm
doctor.
not teaching
Thanks,
you
I got
anything as such. Okay. Okay, so baclofen is a GABA B receptor agonist which suppresses the monosynaptic and polysynaptic reflex transmission and limits the release of excitatory amino acids, glutamate and aspartate. Neuromuscular transmission is left unaffected by baclofen. It is thought to reduce pain sensation, and the drug has an important role in the treatment of neuromuscular disorders, including cerebral palsy. Now, you do not really need to go into the detail of the amino acids as such, but you should know what the mode of action of the drug is. Now, pharmacology is something that many candidates find very difficult because it's something that we study during our med school. So always try to go through a little bit of basics. What are the definitions of pharmacokinetics, the definitions of pharmacodynamics, the efficacy, potency. You can be asked a simple definition, but if you do not remember the definitions, then you might have a problem there. The autonomic drugs are very, very important. The receptors, the agonist, and the antagonist. You should know what are the alpha agonists, the alpha blockers, the beta blockers, which are the cardioselective ones, which are the non-cardioselective ones. You should know all about those. You should know about the drug reaction. The drug reaction. When do you find when will the patient develop Brenman syndrome? When the patient will develop Rayman syndrome? Simple drug reactions that are very commonly seen. For example, lupus in patients who are taking particular drugs. You should know which drug cause a lupus-like reaction. So these are very important to know for the exam. But take some time out for pharmacology separately and try to revise it again a little bit for the exam. Now, question number 9. Again, this is something which the IMGs find a little bit difficult because infectious diseases are very heavily tested on the exam and they're asked in a variety of different ways. So let's just solve this question and then I'll let you know how to study for infectious also. A 45-year-old man comes to the emergency department with a wound to his left hand, sustained when he was separating his dog from another animal. So you get to know that he's got a dog bite. Then he has washed his hands soon after the injury, dressed it up, and is up to date with the tetanus vaccination. You can see 3 clear puncture wounds from the teeth. Sensation of the hand and muscle functions appear to be normal. Which of the following is the most appropriate antibiotic intervention?
Coamoxiclav.
Coamoxiclav.
Amoxiclav.
Yes. The answer is coamoxiclav. Whenever you have you have a question where they're asking about dog bite, cat bite with multiple different organisms that could be present, so you have to give coamoxiclav. It's the first choice agent for prophylaxis against dog bites. All dog bites to the face, hand, foot, and genitalia, or those that require
C is the
surgical
answer.
debridement require treatment. It is given at a dose of 625 mg 3 times daily. Pasteurella is a pathogen most commonly isolated. So this is also asked if you've been asked which organism would you find in this patient. So there you could have marked Pasteurella. So again, in infectious, you are asked a lot about the gram-positive, the gram-negative organisms. You're asked about the antibiotics of choice. For example, you have syphilis, you have focal infections, you have meningitis, you have endocarditis. So there are particular treatment regimens for each of these diseases that you should know. Then vaccination and prophylaxis. Both of these things are very, very important. You have to ask, you should know about the vaccination in HIV populations. You should know vaccinations in pregnant populations, in children. So all these things are important. Then prophylaxis, malaria prophylaxis, tetanus prophylaxis, rabies prophylaxis, all of these things are very important. You should know about the needle prick injuries. They are very important. The prophylaxis, HIV and hepatitis prophylaxis and needle prick injuries. They are very important. And then whenever you are studying about infections and antibiotics, always keep in mind about pregnant patients and penicillin allergies. So you can get a question where you have a question which is similar to this, and you can be asked, the patient is pregnant, now what will you give? Or the patient has an allergy to penicillin, then what will you give? So you should know about that as well. Along with that, if you have viral organisms, then again, viral organisms are very important as far as vaccinations are concerned, prophylaxis is concerned. pregnancy related things are concerned. So that is what we need to keep in mind. Now, the last
Excuse me,
question
what
that we will,
about anti-rabies?
sorry,
Generally about anti-rabies in human bites and animal bites.
sorry,
As general.
I don't get. Can you please type your questions? I'll read it. So let's go to the last question for today, and then we'll take all of your questions. A 74-year-old woman who was taking fludarabine-based regimen for chronic lymphocytic leukemia is admitted for a routine blood transfusion as her hemoglobin has fallen to 5.8 grams per deciliter. Why is she to have transfused with irradiated blood? Now they're already telling you that she is being transfused with irradiated blood. Now why do you need irradiated blood? Any idea?
Depletion of donor white cell.
Yeah, depletion of donor white cells.
That was the correct option. That patients with chronic lymphocytic leukemia are prone to developing transfusion-associated graft versus host disease as a result of white blood cell contained within the donor unit. Irradiation of the red cell unit for transfusion is the most effective way to cause white cell depletion and protect against the transfusion-associated graft versus host disease. And fludarabine is particularly associated with increased risk. And then the other example of indications where irradiated units include immunocompromised hematopoietic stem cell recipients, then patients with hematological disorders who will be undergoing marrow transplantations, then intrauterine transfusion, neonatal exchange transfusion, premature low birth weight neonates, Hodgkin's lymphoma, and congenital immunodeficiency. So basically, what you need to know in hematology and oncology, again, it's very heavily tested on the exam. You should know all about hematological malignancies, the mutations, the good prognostic factors, and the bad prognostic factors. They're mentioned in all of your books, in all of your question banks, so you should learn them very thoroughly. This is one of the very few things that you need to actually memorize for the exam. Then oncology in general, you can be asked about pancreatic tumor, breast tumors, or you can be asked about colonic CA. So you should know the mutations, the markers, and prognostic markers as well. Then oncological emergencies are very important. You should know about that. And then transfusion and transfusion reactions are very important. One more thing that is important in hematological malignancies are the mutations that are important, like in Burkitt's lymphoma, what mutation is present, follicular lymphoma, which mutations are present, which markers are present, like in Hodgkin's you get CD30. So these are the specific markers that are present, so you should know that as well. So any questions? We can take your questions.
I actually have a question. Is it easier to just do a lot of mock papers or MCQs, or because I'll be attempting my exam in November? So is it better to do a lot of MCQs, or should I go through theory also, or just go through the MCQs and related theory?
MCQs, the more you practice, the better you will be. But some theory, I will not recommend going through a very detailed textbooks like Davidson or Harris or anything of that sort. But if you find some topic to be difficult, then you could just skim through that. And the notes that I recommended are only used they could be anything shorthand that you've made yourself, or if you do some pre-made ones. They're only meant for revision, but if you can remember recall material on the basis of your MCQ solving practice, so that is good enough. A lot of people don't use any books.
Also, how is the distribution of marks? Because I really never understood if it's equal distribution of marks. Do each questions have equal distribution of marks?
Now that is something that that is not clear. There's no written and no written documentation present whether each question has the same marks or every question has different marks. But it is assumed that questions which are more difficult have a higher percentile than those which do not. But there's no written evidence as such. So when you're solving the exam, you do not know if it's a question which has a higher weightage or which doesn't. So I will not recommend anything as such.
Sure. Okay.
Any other questions?
Hello.
Hello.
Can I do
Okay,
this?
doctor, can hear you. Can you be a little louder? I can't hear you.
This one is easy for special graduates or not?
Sorry,
The
can
part
you
one.
be a little louder? I can't really hear you.
This part one for freshers you can do is easy or any tough? Actually, I'm asking. I'm a fresher of graduate, special graduate.
You're a
So
recent
this
graduate
is
and you're asking if it's easier or
yeah,
it's not.
yeah.
It's easier for recent graduates in the sense that your clinical medicine is already very fresh. Your pharmacology is very fresh. Although your final year medicine, you must have studied final year medicine. So a lot of concepts will be very, very clear and very fresh to you. So all you need to do is you need to practice the question banks a little more thoroughly. And I think you'll be good to go.
Okay,
See,
thank
no
you.
exam is actually, nobody can claim if an exam is difficult or if it's easy. It's doable. A lot of people do it. A lot of candidates all over the world are able to pass the exam. It depends on how well you prepare for the exam. But if you've cleared your final year, if you're a recent graduate who's just done your house job or your internship in your home country, then I think you're good to go.
Okay, thank you, ma'am.
Hello.
Hello.
I wanted to ask what's the latest criteria for appearing in MRCP-1 exam?
The latest criteria is that you need, after your graduation, you should have done 1 year internship or your house job, whatever is applicable in your country. And then after that, you should have 1 year of clinical practice. So if after your house job, you can apply for it.
Other than house job, you should have 1 year experience, right?
No, including your house. Immediately after your house job, you're eligible for that.
Okay, done. Thank you.
Hello. Hello.
Hello.
Can you tell me its eligibility for mandatory for council registration for appearing to part one?
Sorry, I can't really hear you.
It's a mandatory council registration ma'am, for appearing part one because I can't get registration. Council registration compulsory.
I'm sorry, I can't hear you properly. Can you please repeat your question?
I believe
It's a
he's asking
mandatory
if
for
medical registration necessary. Is it mandatory before appearing for the
Medical
MRCP?
registration where in your home country?
because I'm a recently graduate ma'am. I can't get registered. So it's okay.
If you're a recent graduate who have your medical license in your home country, you can apply for your MRCP exam.
Can we do the GMC registration along with MRCP-1, or do we only do it after passing MRCP-1 exam?
GMC registration is after your MRCP part 1, 2, and PACES along with your OAT. Then you get your GMC registration, not only on the basis of part 1.
Oh, oh.
Sorry, regarding in the UK, after MRCP 1 and 2, you can find as a clinical attachment, right? Or
That is something else. That is a completely different pathway. That is the MTI pathway. That is completely different.
sorry, what's
That
completely?
is another pathway. That is not the usual GMC registration pathway. That is the attachment pathway is another one.
Okay, because I mean, if someone is not doing a registration in the UK, GMC registration as BLAB, and wanted to join MRCP 1 and 2, then after that, how to get to MRCP 3, which is basis, without, if one is not practicing the job in the UK, how
You can apply for that does not require practice in the UK. It requires clinical practice anywhere in your home country. Also, you can practice. If you're practicing in your home country, you're eligible for PACES exam. The PACES exam does not require clinical practice in the UK.
Okay, so no need for this. Is like if I'm practicing in my country, no need between MRCP 2 and the basis to be is like clinical attachment in the UK, right?
No, it's not a compulsion. People do it because they get more familiarized with the pattern of the exam. It is not a compulsory requirement for the exam.
Oh, okay, thank you. That's good. Yeah. There is something is called is that pathway is called medical training initiative, right?
Yes, that pathway is called
medical training initiative. Do you recommend that one, or what do you think? Because I'm in the UK, I'm not sure. Do you recommend that one? Is like after going after MRCP?
That is after MRCP part 1, and then you have to clear your IELTS or the OAT exam. There are 2 requirements for that: the MRCP part 1 and the OAT or the IELTS. And you have to apply to the Royal College of Physicians for that.
Royal College, sorry?
The RCP website, the Royal College of Physicians website.
Okay, so after MRCP 1, so it's not 2.
No, not 2. Only 1 is required. 1 and the OAT is required.
Medical training.
Doctor, what is the name of this program? Medical Initiative what?
Medical Training Initiative, MTI.
Yeah, yes, thanks.
And
any questions regarding the preparation of MRCP part 1? I think that would be a little more helpful for you when you're starting your preparation.
Yeah.
Any questions regarding the preparation, the course material, anything as such?
Our questions usually repeat like in the MRCP exam, because like when I do mock papers, certain questions are repeated. So for the actual exam, would I be expecting certain repeated questions?
Certain, I do not think so. Questions are not actually repeated. The concepts are. The questions are not repeated.
Okay.
Because everything that we see are what recalls. They're not actual true questions. So people have something in their mind, they come back, they just recall those questions. So they might appear to be similar, but I don't know if there's no guarantee that any question might be repeated or not.
Okay. And
but
also normal
practice. If you have a good practice, if you know your concepts well, you will find everything to be quite familiar in the exam. There won't be anything new that you've never heard of or that you've never practiced it before.
Which online?
And normal values are given, right, for the MRCP exam when they give values?
I couldn't hear you properly.
Do they give the normal values? Do they give the normal values of investigations?
Yes, the normal values are given, but I would recommend that at least learn a few important ones.
Okay.
Not all of them, but at least the important ones, so that you do not waste time in trying to compare the normal ones with the given values. So you just know that they're normal or they're not.
Okay. Are we allowed to take our pencils and highlighters or markers?
No,
Or do they-
highlighters are not allowed. Highlighters are not allowed. Only
not
pencils.
allowed? Only pencils.
Only
Do we
pencils.
carry our own pencils or do they provide us with it?
That depends from center to center, but as far as I remember, I took my own pencils.
Okay. Thanks.
When you start solving your mock exams, you will feel that a lot of questions are repeated. That is like, for example, if you're asked about mutation in acute lymphocyte, if you're asked about mutation in chronic lymphocytic leukemia, you will be seeing that question again and again, for example. So just to keep in mind that chronic lymphocytic leukemia is repeated on the exam, not to recall to that particular mutation or particular thing in particular, but in general to know that yes, you have to know about chronic lymphocytic leukemia. If you're lucky, you might have the same question, but you can't always rely on the fact that it will be repeated the same way.
Okay. Do they provide us with calculators or
No.
statistical
No
things?
calculator. There are there's no questions where you need a calculator. The questions that even in biostatistics that you will get would be actual whole numbers that you can simply divide. Like it will be like 30 divided by 6. It will never be in a decimal or in an odd number. It will be something you can easily calculate.
Hello, madam. What you recommend, past medicine or past test online subscription?
See, that completely depends on which question bank you are comfortable with. Nobody can recommend another question bank for another person. So you can ask your peers, you can go through PDFs and see what you're comfortable with, and then you can choose on your own.
Okay. And is it online or means computer based or it is conventional?
Some centers do offer online exams, but in Pakistan, there's not any online exam where I gave my exam. So that depends on your country if they offer an online exam or not. I think so far the online exam is only available in the UK, as far as I know. Otherwise, it will be a conventional exam on paper. You'll have a separate question paper and a separate answer paper, and you have to mark the answer on that answer paper.
Okay, ma'am. And last question, do you recommend in the last 10 or 15 days past papers to be solved like this mock exam or past papers, at least 5 to 10 of recent years?
Yes, you can. They're all exam recalls. Questions that I discussed today were also examination recalls. So I would recommend you to solve them after you've completed your preparation. A month before the exam, you can start solving them and then use them to revise. If you get a question there, for example, getting on asthma and you feel that you're not confident enough to solve that question, you can go back through to your own question banks and just revise those texts again. So that will help you to polish any weaker concept that you have.
Okay, thank you.
Any other questions?
Yeah, actually, this will be the last, I hope. Because the exam duration is quite lengthy, can we take some snacks with us?
Yes, you can. Yes, you can. Definitely, you can. I would always recommend to take very good rest before the exam because the exam itself is very lengthy. And by the second half of the exam, you get really, really tired. So always take your snacks along with you. Take a good night rest before the exam, and do not panic as such. Do not try to check the answers during the break. Although you're not giving your cell phone back, but people tend to open the textbooks and start revising again. So don't do that. Take some break. Eat. Take a nice light snack. Have some tea or coffee or whatever you like, and then come back again for the next exam in a very relaxed manner, and then you can do it.
Is the break 1 hour between two papers?
Yes, approximately 1 hour.
Is there any distribution of topics in paper 1 and paper 2, or is it the
No,
same?
there's no distribution. Both are completely the same.
Sorry, regards starting of preparation, do you recommend, I mean, any starting with a specific chapter or specific module, or what do you prefer usually for someone starting preparation to start with?
When I start preparing for any of my own exams, I always start with the easiest one, because that's when you're able to do it well, and that gives you a lot of confidence and you're more motivated to study further. So I always start with gastro or something easier that I find easier. So you can start with anything that you find easy and you think that you find very interesting. So you can start with that. Because if you start with neurology or with cardiology, you might get bogged down with the details and you might get demotivated. So start with something easier. Start with either rheumatology or endocrinology or something smaller that you can easily cover in a few days. So that makes you more motivated, and you can then move on to the more difficult topics.
Okay, okay. Yeah, thank you.
While we mark on that OMR sheet, we use a pencil, right? So suppose I marked for an answer, but when I revise it or when I second think about it, maybe I want to change the answer. So I can erase and remark another option.
Yes,
It will
you
not
can
affect,
erase it.
right?
No.
No.
You can rub and you can do that. You can erase your answer. That's the problem. But please make sure that you don't mark it so dark on that first time that when you erase it, it still appears to be marked. So just be careful with that point. Otherwise, you can erase and you can mark again. That's not a problem.
Yes, ma'am. It's my last question. Is MRCP workshop is useful or not? 7 days upcoming year workshop.
Sorry, can you please repeat your question?
Hello, it's a 7 days workshop, ma'am. It's I think November 1st started.
Yes,
It's
this is a
useful.
7-day workshop that will start on the 1st of November, and we'll have some live sessions and recalls and interactive sessions also. And you can contact for the details and they'll let you know. Any other question? Or we could end the session then.
Okay, thank you.
Thank
so
you,
much.
Gaurav.
I need to ask something.
Yeah, sure. Definitely.
I need to ask regarding MRCP Ireland. If I want to appear for that, will the preparation be same for both?
It's almost same, but the little things are a little different. The pattern is a little different. It does not have 200 questions. It has only 100 questions, a single paper of 100 questions. And so you'll have to really go onto their website to see if there's any other change. Otherwise, more or less, syllabus.
Do you have any idea regarding the difficulty level of the questions or the way they ask the questions in MRCP UK and MRCP Ireland? Is it the same or is it a bit different?
Since I have not attempted MRCP Ireland, I don't think I'm the right person to ask that. I think you should ask somebody who's already attempted the exam. They'll be able to guide you better.
Okay, thank you.
So that just one question from a personal experience, like when you prepared for your exam, you went through all the past papers and MCQs. Do you feel it's really helpful? Like there was a similarity when you appeared for the exam, or Was
Yes,
there
I
any?
found that useful. I found that useful because when I appeared for the exam, the language appeared to be very familiar. The topics were very familiar. When I came out of the exam, I did not find any topic or any major thing that I had missed out in my preparation. I felt that almost everything was what I had studied, and there was nothing new that was asked. So I found that to be very helpful for me. I found it that made me very confident about my preparation.
Thanks.
Any other questions?
Yes, I need to ask something.
Yes, sure.
When is the right time to, when you are pretty sure that now I'm ready to book for my exams, like how much preparation you should be having before you are confident enough to pay the fees, and now you should be saying that now I can sit in the exam?
See, this is different for different people. A lot of people, once they pay the fees, then are more focused to study. But from my own personal experience, I get very nervous if I have an exam ahead and I'm not prepared well. So I would recommend that finish your first read of any Q band that you're solving, complete your first read, and then you book the exam. So once you book the exam, then you can start on with your revision. So first complete your first read, know all your concepts, and then book the exam. So that the exam, when you book the exam, it's like 3 months before the actual date of the exam. So in 3 months, you can revise and solve your mock papers and or your recalls and all these things. So always complete your first read before you book the exam.
Secondly, do you think that for one read and one revision and then appearing for the exam, is that enough? Or some
No,
people
not at all. Not at all. At least 3 reads of any Q band that you're solving. At least 2. Not less than 2. Not at
So by that, you mean that before booking the exam, we should be completing our 2 reads, and then
First
we
read.
will. So if we after first we read, if we will book the exam, then we'll have like 3 months. Then within 3 months, will it be okay to do the second read and the revision?
So
And
that will depend on, see, again, this is something very relative to each and every candidate. If the candidate is studying for 7 to 8 hours a day, they can easily manage. If you have a very hectic schedule or if you have a very hectic rotation, then you might not be able to manage. This is something very relative. The thing that I'm trying to say is that do not attempt the exam, do not appear for the exam when you're not ready. So if you think you will be able to complete your 2 reads in the next 3 or 4 months before you're booking the exam, then apply for the exam. But if you think that you will not be able to do it, then don't.
okay. So the 2 reads are at least 2 reads are a must.
Definitely.
Okay.
Any other question? Then the question, then we can end this class, we can end this webinar. Any other question? See, so in conclusion, I'll just conclude the preparation time, since a lot of people had a confusion there. The preparation time will depend on candidate individually, whether you have enough time to prepare or not. Candidate might be they might have a very light other professional schedule, and they might be able to study for 6 to 7 hours per day. Another candidate might have a very busy schedule and he might not have 2 to 3 hours per day. So you cannot generalize all the candidates in one category. So, and the background knowledge is different for each candidate. So the reason that I'm telling you an average of 6 months is something that is that is something very general, and that is something that is a reasonable time to prepare for any exam before you get burnt out. So if you think that you will be able to complete the syllabus in due time in the next 3 or 4 months, only then attempt the exam. But if you feel that you will not get enough time, or you need a little more practice and a little more time, then you should give yourself that time to prepare for the exam well. I hope this point is clear. Okay, now we can end the session. Thank you so much. Have a great day. Good night.
Thank you.
Thank you.